Learn about neonatal jaundice, which is also called as hyperbilirubinemia. As the name itself suggests, hyper means increased, bilirubin amount in blood. Emia is in blood. So it is increased amount of unconjugated bilirubin in the blood. So first of all, let's learn about pathophysiology of it. What is bilirubin? So when the RBCs got destructed, bilirubin get released. Hemoglobin when get breakdown, hemolysis of the hemoglobin release the bilirubin, which is unconjugated bilirubin. Unconjugated bilirubin is fat soluble and it is not water soluble. So unconjugated bilirubin goes to the liver for conjugation. Unconjugated bilirubin goes to the liver for conjugation, which when it get conjugated, then only it becomes water soluble and get excreted through stool or urine. So right now we are talking about newborn. So newborn liver is not that mature so that it can conjugate the bilirubin. So that's why unconjugated bilirubin get deposited in the newborn's blood. So unconjugated bilirubin, as we have already discussed, is fat soluble. So that's why it become deposited in the subcutaneous fat of the newborn, and discoloration of the skin occurs. So this is what is mentioned here, that the unconjugated bilirubin, which is not soluble in water, so get absorbed by the subcutaneous fat of the newborn and yellowish discoloration of the skin occur. So when we call it hyperbilirubinemia, when the amount is more than 12 mg per deciliter. So this is for the term infant. Next is types. In the type, mainly it is of two types, that is physiological jaundice and pathological jaundice. So physiological jaundice occurs after 24 hours of life. So after 24 hours of life, what happens? There is less need of RBCs than the fetal life of the newborn. So the liver of the newborn is not that mature to handle that much load of destructed RBCs. So it get accumulated, unconjugated bilirubin get accumulated because it is not get conjugated due to immaturity of liver. So in the after 24 hours of life, physiological jaundice can occur in most of the newborns, but it also get resolved by 5 to 7 days by breastfeeding, because breastfeeding has colostrum, which has a natural laxative effects, which helps in the eliminating of the bilirubin rich meconium. And second, if we talk about pathological jaundice, it occurs during first 24 hours of life. So it occurs because of excessive RBC destruction, which can occur in RH incompatibility, or it can occur in ABO incompatibility or fifth disease. There are a lot of factors which can result in pathological jaundice. The first sign is that it occurs before first 24 hours of life. So in this case, breastfeeding alone is not important. There can be a need of phototherapy as well, which is called as Billy light, in which we use the blue light to treat the jaundice. And in severe cases, there can be need of exchange transfusions as well. Severity can be how much, like bilirubin levels more than 20 mg per deciliter, or if we talk about preterms, it can be even more than 14 mg per deciliter or up to 14 mg per deciliter. We need to use the exchange transfusion, in which 5 ml of blood is like transfused, exchanged, and there are a lot of cycles used to do this whole process. But in this case, there is risk of electrolyte disturbance. There can be hypokalemia or hyperkalemia. We will discuss about that later on. So next we will start about assessment. In assessment, what we need to do is monitor for the presence of jaundice. So presence of jaundice, can how can we like monitor the presence of jaundice? We can examine newborn skin color in natural light, not in the normal like dark lights or room lights. We need to check in the natural light only. For that, we can like press over the bony prominences of the newborn to check the blanching, and also on the tip of the newborns to press out capillary blood from the tissues, because that blood get deposited and we can get to see if it is pale or not. Next is note that jaundice starts at the head first and spread out to the chest, abdomen, arms and legs and hands and feet. So that are the last to be jaundice. So if you are having any sign that the patient is having yellowish discoloration of the feet, so that means you can get to know that it is the last one to get stained. So you need to intervene more early. Okay. And next is use the transcutaneous bilirubin testing if available. So in this you can use the transcutaneous bilirubin testing, or what you can do is TSBs. So in TSB, what is TSB? Total serum bilirubin, which is which is done by the capillary blood of the newborn. So these are the assessments. And next is to assess the skin color every 4 to 8 hours with the phototherapy light turned off, not in the blue lights, with the phototherapy light turned off. We also do this because in phototherapy children there is a risk of bronze baby syndrome, which is grayish brown skin discoloration. So we need to assess that intermediately. And newborn should be repositioned every 2 to 4 hours so that patient can get the adequate blood circulation in the body, and provide stimulation and interaction. That is very important. We need to interact with the newborn by taking off the eye shields, and also skin to skin contact should be maintained with the mother. So after the phototherapy is stopped, we need to check for the rebound hyperbilirubinemia, which is very important. So in this, bilirubin levels can rise again when we turn off the phototherapy. It can like rebound, so we need to check the if there is rebound bilirubinemia or not. So next we will discuss about the phototherapy. So what is phototherapy? Phototherapy is a Billy light or Billy blanket. It is a use of intense fluorescent lights to reduce the serum bilirubin levels. Phototherapy is Billy lights or Billy blankets, which is used of intense fluorescent light to reduce the serum bilirubin levels in the newborn. Okay, so what can be the adverse effect of this? There can be eye damage, there can be dehydration, there can be sensory deprivation. What is sensory deprivation? Patient is not able to communicate with the eye contact, there is no skin contact. We need to put the baby in the phototherapy, so sensory deprivation can occur because of this. So interventions. So whenever we are having a newborn in phototherapy, so first of all we need to keep the newborn well hydrated so that the blood volume can be maintained. For this we need to exclusively breastfeed the infant every second hourly. Second is to facilitate early and frequent feeding. Okay, so this will also help in passage of meconium and encourage the excretion of bilirubin. As we already say, breastfeeding has laxative effects to excrete out the extra bilirubin accumulated. And third is to we encourage the parents to keep a log of number of feedings, wet diapers, like maintain the intake output of the patient, and also check for the stool because stool color can be green. Okay, and some parents get scared of it, so we need to educate it that it is normal finding. Fourth is to report the healthcare provider if you are having if you see any sign of jaundice before the first 24 hours of life, so that adequate intervention can be taken, and prepare the phototherapy for that. For phototherapy, what you will do is maintain the proper distance between the blue light and the newborn, and also closely monitor while patient is on the phototherapy. So phototherapy care of newborn can be done by exposing the maximum skin to the phototherapy light. For this we need to cover only the genital area and the eyes, and rest of the body should be exposed to the blue lights, and keep the genital area and eyes covered. Eyes should be like eye shield should be placed first and then put on the billy bands, because when the baby will open the eyes inside the belly band, there can be a risk of irritation, and for that irritation we need to check every shift for the irritation or infection in the newborn's eye. Okay, and next is to check the lamp energy output. It is very important because if the lamp energy output is too high, there can be too much like warming or burning of skin of the newborn. So skin temperature should be also monitored because blue lights are already warm, so skin temperature should be maintained. Increase the fluid intake if the patient is not properly intaking the breastfeeding or taking the normal formula feeds, then we need to start with the fluids as well. Maintaining the IO, we need to check the weight of the newborn daily, and as we have already discussed, possible loose green stools or green colored urine. This should be explained to the parents. So this is all about the phototherapy care. Next, we will discuss this question from NCLEX. The postpartum nurse is providing instruction to the parent of the newborn with hyperbilirubinemia who is being breastfed. Nurse would provide which instruction to the parent? So, first is feed the newborn less frequently. Less frequently? No. This is wrong option. Continue to breastfeed every 2 to 4 hours. Yes, this is right. Every 2 to 4 hours, you need to exclusively breastfeed the newborn. So third is to switch the bottle feeding the infant for 2 weeks. No, we do not recommend the bottle feeding to the infant because it can affect adversely. Next is stop the breastfeeding and switch to bottle feeding permanently. No, we never recommend the bottle feeding. So the second option is right, to breastfeed every 2 to 4 hours. So this is all about neonatal jaundice. We can later on discuss more about this. One thing is left that there is a CNS effect of the jaundice as well. CNS effects of the jaundice is called as connectors, which is permanent staining of the brain tissue, which is like a major problem, or it can also cause intellectual problems in later life. So we can discuss about this in next lectures. Thank you.